can go.
This presentation covers gastritis. The pathology of the disease begins with such that gastritis is an inflammation of the gastric mucosa. Gastritis may be acute or chronic and diffuse or localized. Gastritis occurs as a result of the breakdown of the normal gastric mucosal barrier. This mucosal barrier normally protects the stomach tissue from the corrosive action of hydrochloric acid and pepsin. When the barrier is broken, hydrochloric acid and pepsin can diffuse back into the mucosa. This back diffusion results in tissue edema, disruption of capillary walls with loss of plasma into the gastric lumen, and a possible hemorrhage. Diagnostic testing for gastritis. Acute gastritis is usually diagnosed based on the patient's symptoms and a history of drug or alcohol use. Occasionally, an endoscopic examination with biopsy is necessary to provide a definite diagnosis. Breath, urine, serum, stool, and gastric tissue biopsy tests are available to assess for H. pylori infection. A complete blood cell count may show anemia from blood loss or lack of intrinsic factor. Stool tests are tested for whole blood. Clinical manifestations of the disease. The symptoms of acute gastritis include anorexia, nausea, and vomiting, epigastric tenderness, and a feeling of fullness. Hemorrhage is commonly associated with alcohol abuse and at times is the only symptom. Manifestations of chronic gastritis are similar to those of acute. Some patients are asymptomatic. However, when vital cells are lost because of atrophy, the source of intrinsic factor is also lost. Intrinsic factors is essential for the absorption of cobalamin in the internal ileum. Once the body's cobalamin stores in the liver are depleted, a state of cobalamin deficiency exists. Interprofessional care that should be provided. So eliminating the cause and preventing or avoiding it in the future are generally all that is needed to cure gastritis. In severe cases of gastritis, an NG tube may be used to monitor for bleeding, lavage the precipitating agent from the stomach, or keep the stomach empty and free of noxious stimuli. Clear liquids are resumed when symptoms have subsided. Reintroduce solids gradually. If the patient is at risk for hemorrhage, frequently check vital signs and test the vomitus for blood. Interprofessional collaboration is done with a physician or gastroenterologist for medication administration and further interventions. A dietitian referral is highly recommended and assists the patient in formulating a diet. Treatment plan and medications for this disease. The priority with treatments is to treat the underlying cause. Drug therapy focuses on reducing irritation of the gastric mucosa and providing asymptomatic relief. H2 receptor blockers such as ranitidine or protein pump inhibitors such as omeprazole reduce hydrochloric acid secretion. Other medications including antacids and antibiotics such as flagyl or amoxicillin to treat microorganisms and anti-emetics such as ondansetron for nausea and vomiting. Teach the patient about the therapeutic effects of these drugs along with the contraindications and how to properly take the drugs. Nursing process and the development of a plan of care. A thorough and accurate nursing assessment is essential. That is the first step. As then followed, the patient must be assessed for their level of consciousness, vital signs, skin color, and capillary refill. Immediate determination of vital signs indicates whether the patient is in shock from blood loss and provides a baseline blood pressure and pulse for monitoring the progress and the treatment. If shock is expected, immediately notify the provider and continue to monitor the patient's vital signs every 15 to 30 minutes. When assessing the abdominal airway, start with inspection, noting for distension. Next, auscultate for bowel sounds, noting for any abnormal sounds including hypo or hyperactivity. And finally, palpate all four quadrants for the presence of tenderness, peristalsis, and rigidity. Once the immediate interventions have begun, the patient should answer the following questions, such as if there is a history of previous bleeding episodes, has the patient received blood transfusions in the past, were there any reactions? If so, Are there any other illnesses or medications that may contribute to bleeding or interfere with the treatment? So again, there's a series of questions that you want to have handy when assessing this patient. Acute GI bleeding management begins with checking if the patient is responsive or unresponsive. If unresponsive, assess circulation, airway, and breathing. If responsive, monitor airway, breathing, and circulation. First, establish an IV access with a large bore catheter and start fluid replacement therapy. Insert additional large bore catheter if shock is present. Give oxygen via nasal cannula. Initiate EKG monitoring. Obtain blood for CBC, clotting studies, and type and cross-match as appropriate. Insert an NG tube as needed, and insert an indwelling catheter. Give IV protein pump inhibitor therapy to decrease acid secretion. After, continually monitor vital signs, level of consciousness, oxygen, and saturation, EKG, bowel sound, and intake and outtake. Assess the amount, the color of emesis, keep the patient NPO, and provide reassurance and emotional support to the patient and the family. Patient teaching should center around management and prevention. Teach patients about smoking and alcohol cessation, teaching them to avoid NSAIDs and aspirin use unless directed, and to follow a healthy diet, but avoid foods that irritate the stomach, such as spicy foods and citrus fruits. Advise on incorporating vegetables, low-fat dairy, beans, whole grains, breads, lean meats, and fishes, and advise the patient to eat small meals and drink water with their meals, and at least 3 hours before bed. And this concludes our presentation. Thank you.